Most of my time is spent looking at hearts that have unusual plumbing or holes in it, because that's what children are born with. But I also do a lot of cardiomyopathy, and Friedreich's ataxia is what I work on as a cardiomyopathy. And so that goes on into adulthood, and I wind up seeing a fair number of adults who have Friedreich's or congenital heart disease. And I'm at Indiana University School of Medicine, and I also work with Chondrial Therapeutics, because I formed the company, which now has moved to Philadelphia. So I know a lot about this disease. I've been in the field since 2003. Been through a lot of mice, a lot of technicians, and a lot of graduate students. So it's an expensive kind of sport, I have to say. But the heart is what I focus on. That being said, I've also examined the neurologic system and the impact of this disease on the neurologic system and its therapeutic implications as well. And I'm happy to talk about that as well. But perhaps we could say where we're from and what's going on. Hi.
Sorry.
You're the mom for this one?
Yes.
Ah, okay. And who are you?
Gina.
Gina, and your daughter is?
Isabella.
Isabella. And you live here in California?
Anaheim, yes.
Yeah, that's very close, right? Okay.
My name is Melissa. I'm from Culver City, Los Angeles.
Okay.
Hi everyone, I'm Sally Lamb from Dallas, and I'm with Rihanna, and we've been studying all that.
Dallas, I grew up in Tyler. So I know Dallas really well.
I'm Colleen Stoyas. I am actually from Carlsbad, California, well, now. And I am also with Rihanna Pharmaceuticals. I joined them last month, but I have a research background in spinocerebellar ataxia.
Okay.
Ed Bennett, my wife Jody. We have a 22-year-old son just last year.
Mm-hmm.
And we're from Salinas, California, out of Monterey.
Okay.
I'm Judy. It's Edmund.
Okay. All right, please.
I'm Jennifer Helms, and I'm from Missoula, Montana, and I have a son, Dylan, who is 17. He's here, and a daughter, Sienna, who's 13, and we both have FA.
Okay.
I'm Ingrid. I'm from outside Chicago. I'm a recent FA caregiver.
Okay.
I'm Suzanne. I have laid onset FA. I've lived with it most of my adult life, and I'm from Chicago.
Okay.
I'm Bill, I'm her husband.
Nice to meet you, Bill.
Nice to meet you.
Please.
I'm Mike Andreessen. I have two sons in their 30s, and so we've been in the FARA realm for 15 years.
You're in California?
And no, Portland, Oregon.
Okay.
I'm Alan Pal. I have a 19-year-old daughter that has FA.
Okay.
From San Jose, California.
J.D. Avushar. I have a 17-year-old son, Charlie, who has FA, and we're in San Francisco.
Okay.
Jen Farmer.
Jim Farmer.
My name is Daniel Cotter, from Scottsdale, Arizona, and I'm the driver.
My name is Nicole Cattle. I have a son, 23 years old, with Friedreich's ataxia,
Okay.
and we're from Scottsdale, Arizona.
Okay. So I'm happy to just open this for questions. But while people are thinking, perhaps one of the things I could go back over has been the heart at scoliosis surgery, which has been an issue in the past, and maybe I can touch on that, and we can use that for a springboard or something else. So one of the areas that I've gotten a lot of phone calls in the past has been when kids are undergoing, or young adults are undergoing scoliosis surgery. And the phone call would go something like this, which is, my son or daughter is either having scoliosis surgery and they're in the middle of it, and things are going very badly, or they finished scoliosis surgery and they're in the ICU and things are going very badly. And usually what would evolve is that cardiac function had declined severely across the time of surgery, and the outcome would be bad. So when you stop and think about what goes on in scoliosis surgery, it's actually a very major surgery. So for those who have been involved, you understand the spine is exposed all the way down, and then there are mechanical rods placed in there. So the procedure itself can lose a lot of blood. and a lot of blood products are usually administered. The other thing that surgeons typically do for this surgery is to avoid blood loss, they will lower the blood pressure so that obviously you bleed less and you have to give less blood products. And then because of the nature of the surgery, which is fairly, I don't want to use the word traumatic, but it does injure a lot of tissue. They frequently require a lot of fluid afterwards. Well, what kind of became sort of obvious was that was the following things to me, which was if you lower the blood pressure in these kids and they happen to have a cardiomyopathy, a really thick heart, it's hard to perfuse that heart when their blood pressure goes down, number one. Number two, if you think about it, if their mitochondria are not working well, then they're not generating adequate amounts of energy, and it makes them, their hearts shift their metabolism away from burning fats, which is what they usually burn, towards glucose, which is what is a very ready fuel substrate. But what they do in surgery is remove all the glucose from all the IV fluids because it makes a really sticky operative field, so you'd rather not have glucose in the field if you can avoid it. And then, again, in hearts that are very thick, that have had a lot of years of damage from the Friedrichs, they get really stiff. So if you give a lot of fluid to these patients, they develop a condition called fluid overload, and their hearts simply cannot pump adequately to get rid of all of that fluid, so they can't pee it out. So this is an issue of a rare disease, and they're having a surgery that's not common, and they're having bad outcome. Not all of them, many of them have good outcome. So there was never enough ability, and I tried this even, to do either a retrospective clinical trial or a prospective clinical trial. For sure we couldn't do that. So what really evolved was best judgment. And one of the other FA parents, after talking with her, she talked with me, she talked to the anesthetist, she talked with the surgeons. She put out a blurb, said that these are the things you should watch out for during surgery, which number one is talk to your cardiologist, your ICU, your surgeon, and make them get together and talk with each other about what the heart is like in this disease. Number two, make sure that they don't drop their blood pressure a lot. Make sure that they don't get a lot of fluids in the post-op setting. And, you know, it's been a long time since that came out that I've gotten a bad phone call. And maybe you guys at CHOP have gotten some, but I have not gotten any more.
I think, yeah, and I think the other thing that recently we've been doing is trying to encourage people to not be glucose depleted or as
Yes.
glucose depleted.
That was the other thing, is to put sugar back into their IV fluids. And the markers that we asked them to look at, which is cardiac troponin, which is the marker we all, you know, if we go to the emergency room with chest pain, they're going to get cardiac troponins on us because that's what we use for heart attacks. People have been following those now. And if the troponin begins to be released in the blood system from the heart, it says the heart's being injured, then they can give blood pressure back and the heart responds nicely. So that's an example where probably best judgment based on understanding the physiology of the heart in Friedrichs has made a difference. I can't quantify that because it wasn't a clinical trial, and I even tried, once again, I tried doing a retrospective analysis by getting the charts of all the kids who'd had scoliosis surgery, and that was very difficult. I wasn't successful. That being said, in rare disease, I think we frequently are stuck with best clinical judgment, understanding the molecular basis of the heart disease or the disease itself and the physiology that goes with it. And I really think that we made a difference in how kids have progressed through scoliosis surgery. Certainly at my institution, the neurosurgeons are more than happy to send me a bunch of emails saying, Mark, what should we do with this? What do you think the heart looks like here? And kids sail through just fine. So this is an example, once again, where best clinical judgment has made a difference in the outcome. And if any of you guys have children or know somebody who's going through scoliosis surgery or has it coming up, or a stressful surgery in general, I'm happy to talk with the doctors or whoever to kind of get them together. But the biggest thing is to recognize this is the physiology of the heart, and Number one. Number two, it's really important for the surgeon to know who's in the ICU, who the anesthesiologist is, and how to get the cardiologist involved. Because sometimes what you found was the cardiologist was never around, or the anesthesiologist just gave a bunch of fluid and pushed them into the ICU. And I'm not disparaging medical treatment by any one or the other. It's just that this is what they typically do for that particular surgery, and all the kids turn out good, except in this case.
Would you like to comment on basically a self-infusion strategy where they store sort of ahead of time blood? Because that's what they used on my son, and it worked quite well.
Yeah.
So
a
then
lot
you
of people do that.
Yeah.
Prior to surgery, you will, like 2 or 3 months ahead of time, you'll go in, you'll get a unit of blood.
Right.
And it's usually at the Red Cross Center, although you can do it in the hospital. And then that's called self-directed donation, a very common procedure. And it avoids the issue of getting somebody else's blood and you don't know what it's been through. That's actually pretty common.
Mm-hmm.
And what it really does is it completely avoids any rejection issue, completely avoids any infection issue. And it, if you've got it coming up within 3 months, I think the shelf life of packed RBCs is 90 days, if I'm not mistaken. So within 3 months, you can go in and have that done.
So I'll emphasize, it is a major surgery, but it really helps with pain and posture. My son once corrected, I think he added like 3 or 4 inches to his height because his spine had begun to move. And so, I mean, it can be very successful. And he's now probably, I'd say, maybe 12 years post-surgery, and he has had no problems since then. So.
Well, that's very good.
So, yeah,
Excellent.
It does work.
Okay. The other issue that we run into with these hearts has been arrhythmias. And it's a kind of arrhythmia that sort of catches me off guard. You would expect out of these hearts when they get really super thick and they're really, you look at the echo and you think, wow, that's a really thick heart. You'd expect what we call ventricular arrhythmias. And ventricular arrhythmias are the ones that nobody wants to get because they're frequently the last arrhythmias that you have. Bless you. So premature ventricular beats that lead into the ventricular tachycardia or ventricular fibrillation. Strikingly, that's really rare in these guys. I looked at some Holters on a few of them, and yes, they'll have PVCs. Quite frankly, I have them all day long because it's just job stress. The arrhythmias that they get are called supraventricular arrhythmias. So they get SVT, tachycardia, which is very common. We see it day in, day out in pediatric cardiology because that's the most common arrhythmia we have in children, SVT. And for us, it's super simple to fix. They also get atrial fibrillation and atrial flutter. That's a bigger issue to fix, and it's probably more important to fix because the atria, whenever they beat, those are the low pressure chambers in the heart, they contribute about 15% of the cardiac output. So if you lose that contribution of cardiac output in a heart that's already on the edge for being able to put out enough blood flow, then they notice that really quick. It also puts them at risk of a stroke. And nobody wants those. The point being,
Are there symptoms of atrial
Yes.
flutter or atrial
there
fibrillation?
are very good symptoms. That's an excellent question. And so for atrial fibrillation, for example, the heartbeat becomes irregular. So when we're all sitting there watching TV, you don't even notice your heart beating. It's so regular. But with atrial fibrillation, you may get 3 or 4 atrial beats, and then one of them captures and goes through the rest of the heart. So your heartbeat becomes, and you notice that right away. The other thing that you notice right away is you just don't have any energy. All of a sudden, your heart is no longer pumping enough blood flow, and you feel it. You really do. So you feel the arrhythmia, and you feel like you've lost energy. That's atrial fibrillation. Same thing for atrial flutter. They both do the same thing. And in fact, the Apple Watches today will pick that up, and they'll tell you you've got AFib or you've got an arrhythmia in your heart. You need to get it fixed. And it's just picking it up based on the regularity of the heartbeat picked up by blood pulse in your ribs. So most people who get that the first time wonder what's wrong with my heart, and eventually they get to the emergency room or to their doctor. The second time they get it, they know exactly what it is right away. But atrial arrhythmias put you, patient, at great risk of stroke, and then the hypertrophic cardiomyopathy that they get, and puts them at risk of so much decreased cardiac output that they will notice it immediately and they will be doing very poorly. Yeah.
Yeah, a two-part question. So
Yeah.
following up on that, is it fairly obvious if you're having an AFib episode for somebody who's not thinking about it, like my son? And then that sort of leads into a more general question of, you know, in FA, it appears that certain symptoms present in certain FA patients differently, right? Some will
Yeah.
have heart issues, some won't.
Yeah.
Right now, we think our son fortunately doesn't, but what should we be watching for?
So that's a great question.
And the progression.
That's a great question. And this is something I've really puzzled about and wondered about how can I get at in terms of basic investigation. The population of FAers, it's not this neat, but it breaks down into two populations. Those guys who got a really thick heart, and those guys who may have FA, but their heart doesn't look that bad. In fact, frequently they are indistinguishable from normal people. The ones who get most of the atrial arrhythmias tend to be in the thick heart category, and I can discuss why that happens. Those who have the normal-looking hearts, they tend not to have those issues quite so often. Although that would be that would be a great retrospective project to look at, and I'm pretty sure FARA's got the database.
Yeah, it does sometimes happen though, where
It
we
does.
do see, especially, you know, 30s, 40s, we see emergence of more arrhythmias.
Mhm.
And so, you know, I think obviously the annual visit to your cardiologist for EKG, Holter, can be important for picking that up, and it's
Yeah.
becoming more and more standard of care at most
is.
sites to get that Holter monitor, not just the EKG, so that you're monitored for the 24-hour period, and we can see what electrically is happening over a longer period of time rather than just the short period of time that the EKG captures it.
So can a heart transition from more normalish to thick?
You know
rapidly or
what,
quickly,
that's
or
another
kind of in column A, column
great
B?
question. If you reach, so this gets back to what, I think it was you, Jen, who brought that up. And I have not yet seen an FA patient, normal looking heart on echo or not, whose EKG looked normal, period. So you can almost pick them out. That being said, I've not seen somebody who has normal function, normal heart wall thickness, who was 17 years of age, who progressed to a super thick heart. Maybe you guys have, but I have never seen that. I have seen the other way, where their hearts are thick and then they get thin. And that's usually a bad sign. It usually means that the heart is so much of it has died that it has begun to thin. So wall stress is exceeding the ability of the heart to maintain normal wall tension. I've only seen one patient where she had a super thick heart, put her on a medicine, and a year later when I saw her back, her heart was normal. The guys reading the echoes called me up and said, "What did you do to her?" And I said, "I just put her on this medicine," and boom, there she was. And she has been fine ever since. She really has. So the hearts that require the most scrutiny and closest follow-up are the thick hearts. And I can go back over that in a minute. Those are the ones who get most of the arrhythmias. And the arrhythmias, once again, are SVT. The heart rates around 180 to 220 beats a minute. And there's no question in the kid's mind, my heart is weird. And they'll come to you and tell you that. And you will not be able to count their heart rate. That's very characteristic. The ones who have atrial flutter and atrial fibrillation, if you put your hand on their chest, their heartbeat is irregular. So if you have an FA child and their heartbeat is irregular, yes, you need to call your cardiologist or your family doctor or your pediatrician or whoever follows this child. If their heartbeat is irregular, you need to call them. We have very simple, they're not simple, we have very reliable methods for picking that up. A Holter monitor, an event monitor that they wear for a month, or a Holter monitor overnight, or even an EKG sometimes. Or Even an Apple Watch will clue you in. So I'm not advocating for Apple Watches. I don't even know them myself. They can help. The cardiomyopathy that these guys get is a very unusual kind. It's a very thick heart. It's a lot of fibrotic tissue. So what happens is they don't get heart attacks. They don't get so part of their heart doesn't die. What happens is they have interstitial fibrosis. So fibrous tissue forms throughout all the heart, and they've probably got ongoing cardiomyocyte death all along. That's what's been shown in the mice. And when you look at their hearts at the time of death, that's what they have as well, if they die from their heart disease. So what does that do? Well, fibrous tissue does not expand. Cardiomyocytes have the unique characteristic that they'll expand to accept whatever volume of blood they got charged with, and they'll pump it right back out. But if you have a lot of fibrous tissue in your heart, which is what happens to all of us as we get older, then the heart loses its ability to expand. Okay, so it becomes fixed. And that's why they do so poorly with a lot of high fluid infusion during scoliosis surgery, or if they go to the emergency room and they get a couple of liters of normal saline, they'll do bad because the heart cannot expand to pump that blood. And as a result, they get fluid overloaded. The reason that's called diastolic dysfunction. It is one of the components of heart function for which we have very poor therapies for. In fact, it's the undiscovered frontier of cardiology, is how to fix the resting phase of the heart so it pumps acceptable blood. I'd love to be able to fix that. And as a result of that, because they can't expand their ventricles, eventually the atria, those are the chambers on top you get atrial fibrillation or atrial flutter from, they begin to respond badly to that higher pressure, and they dilate over time. And that's actually what happens to many of us as we get older anyway, and that leads to atrial fib and atrial flutter. So when that happens, again, we have to treat the underlying cause, which is too much fluid going in. It's usually not the pumping action of the heart. That seems to actually be maintained for a long time, even when their hearts are very sick. It's the ability to relax that they're compromised with. So we have to control the arrhythmias. That's always keying in my book. So if there's bad rhythms in the heart, atrial fib, atrial flutter, SVT in these kids, we need to control that because that really does matter to their sense of feeling good and their overall heart's ability to pump.
And those are addressable, right?
They
There
are
fixes
addressable.
for
They
those.
sure are.
And
They sure are. We just need to know about it ahead of time, and we need to educate you guys. So if your son or daughter is saying, my heart feels funny, or I'm just out of gas these past few days, feel their heart rate. It should be regular. Even in an FA patient, it should be regular. And if it's not, if it's bump, 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 yeah, call your family doctors or whoever, and let them know, because they'll get them in and we'll put a Holter on them. It's very easy to do, and we can treat that. The other issue that comes up, and I get this a fair amount too, is chest pain in the FA patient. Okay? Never had an FA patient complain of this, and they've got a normal thickness heart that is functioning just fine. It's usually in the guys who have really thick hearts. They get chest pain. They have nothing wrong with their coronary arteries. But if you check their troponins in the blood, they've got low-level leak all the time, which tells me they've got ongoing cardiomyopathy and sickness in the heart muscle. And yes, I have had to treat that even with standard anti-anginal chest pain drugs that we use in older people. And that helps. But sometimes they get chest pain, and you're stuck with what can be causing it. And I don't have my finger on that at all yet. But they do have microvascular disease inside their heart. Disease of the small blood vessels that feed the heart directly, not the big coronaries, but the little tiny blood vessels that feed in their hearts. And they may actually have localized ischemia in their hearts. And yes, there are medicines that we can give them to help fix that as well. So the things that I've really clued in on these guys have been when they go for stressful surgical procedures, there needs to be good communication with whoever's doing the surgery and proper maintenance of their surgical management. And they do get arrhythmias over time. And we can manage those. Number three, yeah, they can get chest pain from time to time, and we can manage that as well. Sometimes the chest pain, quite frequently the chest pain, is not due to the heart at all. One of the things I see most commonly in my clinic are teenage people, girls mostly, but boys also, who come in with chest pain. And it's like, I'm gonna die. And 999 times out of 1,000, it's stress, anxiety. And that especially crops up in these guys, because they know that they've got a severe disease and it's not gonna get better. So that's the first place that I usually go, anxiety. And yes, it causes chest pain. It's not from the heart. It can be caused by the muscles. They have hyperventilation. The diaphragm can develop muscle spasm because they're simply breathing too hard and too fast. Or they've got, when you're anxious, you get adrenaline release and your heart begins to pound harder. Yeah, that's very uncomfortable. And frequently young people express that by saying, I've got chest pain, something's wrong with me, I'm going to die. And so when you talk them through that, they're usually okay. But I see that day in and day out.
You take them to the ER. Apparently, they show a raised level of an enzyme, so they think in the ER your kid's had a heart attack.
What's that?
Sometimes you'll take them to the ER,
Yeah.
and the levels of one of the enzymes are so raised.
Cardiac troponin.
Yes, the cardiac.
So,
What do you tell the doctor then?
That's a really good issue. Lots of kids go to the ER with chest pain. I think most ER docs today recognize that kids have chest pain, but it ain't their heart. Okay? Friedrich's is different. If they go to the ER and they've got chest pain, they're going to get a cardiac troponin because that's what everybody does.
Yeah.
And yes, it will be elevated. So if that family calls me, and yes, that happens, or if the ER doc calls me, or if the family wants me to call the ER doc, the first thing I usually find out is, have they had chronic troponin leak all the time? And all they measured was what the kid's leaking out of the heart all the time. So this is nothing new. And as a result, usually what happens is I make sure, or I talk to the emergency room doc, the rhythm is okay. If it's okay, then that takes a lot of it out of it. 2, their EKG, it should not show an infarct. Sadly, most pediatric EKGs, when interpreted by an adult cardiologist, says infarct, heart attack. And that's just the nature of pediatric EKGs. That's why you have pediatric cardiologists read their EKGs, not adult cardiologists. But I usually talk to them about that. And if their EKG is fine, then they're not having a heart attack. Children don't have heart attacks unless they've got some unusual structural abnormality. That being said, the Friedrich's heart will leak troponin when it's really thick, and the reason is not clear, but probably it's ongoing cardiomyocyte death from the disease process itself. So when that happens, ask the ER doc to check the EKG, to check the medical records to make sure that this isn't something new. The troponin has always been leaked, or it comes and goes. And to calm the patient down and make sure that it's not just anxiety that's causing this issue. But heart attacks in young people, they're just really, really rare. There are some things that they can do. Snorting cocaine will do it. That will give you an infarct, a heart attack. But that's usually not these guys.
Yeah, so I just sort of 2 questions. One is related to this. So my daughter sees the cardiologist, she gets the echocardiogram once a year right now. And, we talk to them about the thickening of the heart, and so they monitor for that. I'm assuming they look for all the standard things that could go wrong. Is there anything else, given that she has FA, that we should be asking them to monitor or watch for, and then specifically this troponin level?
So
should we be,
when kids come in to see me on a yearly basis, I'll always get an EKG and echocardiogram, and that's standard. I may or may not get a Holter, depends on what's going on, but if they haven't been having a problem, then I don't do that. I always get a lipid panel. And I always check hemoglobin A1C, and I always check cardiac troponin, I. Excuse me, I'm kind of running out of gas.
Can we
These
get a
are-
list of these things?
What's
I
that?
don't- Can we get a list of these things so I don't have to try to remember?
I'm happy to send a list, but I think you guys probably check the same things. Their lipid panel tells me a lot about their lipid panel usually shows that their good cholesterol, HDL, is low, lower than you want it to be, and that their bad cholesterol is high, higher than you want it to be.
Just like that.
Yes. The reasons behind that are not clear, and I don't want to speculate. For cardiac troponin, if it's a thick heart, I expect it to be leaking all the time, and that's what I see. What I'm really looking for in particular is hemoglobin A1C, and hemoglobin A1C is a really good marker for diabetes, and if it's elevated or up near the top, then yeah, I begin to look at these people, these patients, for diabetes and its impact on the heart. So the impact on the heart of chronic diabetes is that they get small vessel disease within the heart. And if they've got a thick heart, that makes it even harder to push blood through the deepest parts of the part that's right next to the pumping chamber. And so that helps me in terms of management going forward. If they come in with, I don't want to go back into the chest pain argument, or discussion, but if they come in with chest pain and I know they've got high levels of hemoglobin A1C, and I know that they've been leaking troponin for a long time, then yeah, they may actually have cardiac disease that's causing chest pain.
So the three things that you mentioned, is that something that a quote-unquote normal visit to the doctor for an echocardiogram they would check, or is that something that we should be asking them to do specifically?
Yeah, I think most cardiologists, if you go to see them on a regular basis once a year, they will get an echocardiogram.
Yeah, she gets the echocardiogram. I just don't, and the only thing I've spoken to them more specifically is the thickening of the heart, but they've never mentioned the troponin level.
I don't think it's widely known.
So it's something that we
this gets
should
back
be
to the-
asking.
Yeah, we're actually going through an update of the clinical care guidelines this year.
Okay.
Because things like getting an annual troponin aren't in there, yet we now know that people should be
Maybe
getting
we should be doing
troponin
that,
checked
yeah.
on an annual basis, so that when they do have to go to the ER for some reason and they find it elevated, they'll have the historical one that Dr.
Yeah.
Payne was talking about. So some of the recommendations do need to be updated from when we
Yeah,
did
so
the
those
last.
would be very helpful. Because
Yeah,
otherwise,
we're-
we're sort of at the mercy of whoever the cardiologist is in
Um,
terms of what they're checking for, because we
Yeah.
don't know
If you're
what
asking me to
questions
help
to ask.
update the recommendations, I'm happy to do so.
Yeah, you're gonna get asked for that. Don't worry.
We're asking.
What I'm really needing you to think about is for your children, if you can maintain a little hand chart that you take in and you show the doctor, the ER doctor, this is what my child has been doing, then it might be a new ER doctor or a new emergency room. They don't have to go scrambling around to try and figure out, does this troponin mean something or not? Well, it always means something, but it's not new to your child.
Yeah.
So that means it's not a heart attack, because that's the way all emergency room physicians are trained to think. It's a heart attack, I gotta do
Yeah.
something about it. And the last thing these guys need is a cardiac cath. That's just not what they need.
Yeah, and it's pretty easy now. Most physicians have online portals for medical records, and so you can access that kind of stuff pretty easily. The hard part is being diligent about pulling the information off and storing it someplace before there's
Yes.
a problem, so that
Well,
when
and
there is
also
a problem,
knowing
you
what
can access
information
it
we want
easily.
them to check for and store, so that's where these guidelines will definitely
Yeah.
help
Well,
us.
the
Because otherwise,
guidelines will help you too, because the closest I've ever had to take my kids to the ER was when we had to take her daughter there, and I almost needed to be hooked up. You know, if it was my kid, I wouldn't be able to think, and I'm a pharmacist, so I normally
Yeah.
think some parts of the day. But that part, I would lose my mind, that I'm sure of. So to have a portal, like you said, or a checklist ahead of time, try and remember what troponin is for the first place, what's leaking out of the heart, whether it's SGOPT or SGPT, all those stuff, sugars. How could you think that in a second? You
Yeah,
know,
no,
how could you-
I agree.
I mean, I went in the emergency room one time because one of my patients got me so scared. Turned out it was because I had had a couple cigarettes the day before and ate too many of those little beef sticks and a bunch of coffee that day and didn't eat dinner for 2 months. And boom, you know, that could happen to these kids with the Mountain Dews and all that kind of stuff too. You know, who knows? Not necessarily if I'm kind of stepping out of And you're around there, I should be talking to you.
Beef sticks and cigarettes are really bad.
It was kind of a weird weekend.
Is that the clinical guidelines?
Yeah, you shouldn't need a guideline for that.
Another checklist, don't do that, but.
I have no idea what troponin is.
Okay, so that's a good question. What's a cardiac troponin? So in cardiology, we measure certain enzymes or proteins in the blood. In medicine, we measure these all the time, and they tell us what organ released them and how bad it was. So in the old days, and old days mean when I started my cardiology fellowship, we measured creatine kinase release into the blood, CK, and that eventually was replaced by enzymes that are extremely specific for the heart. And troponin is a contractile protein in the heart itself. Cardiac troponin I and cardiac troponin T. Well, cardiac troponin I has been shown in multi-10,000 studies, studies with tens of thousands of people in it, to be really specific for heart attack and heart damage. Cardiac troponin T can be released from the heart when the heart's not being damaged. They might have been in a car accident, for example, or played sports. But cardiac troponin I shouldn't find it in the blood. If you do, the heart is releasing it, and it says that's a bad thing. The adult cardiologist will tell you if you've got chronic troponin leak from your heart, troponin I, that's a bad harbinger of cardiac performance over the long term. So yes, I follow this, and it tells me, is this heart being stressed? Is it injured? If you have a track record of a heart that does not release cardiac troponin, but they have to go in for scoliosis surgery, and during the surgery the surgeon is tracking troponin, and it goes way up, that tells me that heart is being injured during surgery. Okay, so that's where that becomes clinically very useful. So for me, once again, when I see these kids in clinic, once a year I'll draw a cardiac troponin I on them. And cardiac troponin I is a contractile protein in the heart. It is released when the heart's being injured. So if you see that, it's a bad sign.
So should that be something when she sees her cardiologist again that I should request?
Yep.
Okay.
But that kind of gets back to the guidelines issue. This
There are
comes
a
down
few
to
papers now that have been
Yeah.
published, so
Yeah.
if they go to the medical literature, like you can tell them that they can look it up, Friedreich's ataxia and troponin, and they'll see some papers that talk about troponins being elevated in FA patients, so they can find medical literature, but we're gonna take those papers that have been published and kind of update the guidelines so that they don't have to dig for that, and it just says, here's what you should do.
Yeah, that would be
But for
great.
the parents, Jen, why don't you just have a little table that people can fill out and keep, according to dates, and that way you can track it over time.
Yeah.
That's actually
So
a good
serially.
idea, especially if it was something like, I don't want to say an Excel spreadsheet, but you can make them
Just
so
a
they don't look like
PDF,
that.
Yeah.
You just check the
fill in the
box.
blanks.
Yeah.
That's a great idea. Again, Friedreich's ataxia is a rare disease, but more specifically, the heart disease that comes from it is very unusual. And most of the adult cardiologists, where most of your kids are going to be seen eventually, are trained on a completely different form of hypertrophic cardiomyopathy. And it has nothing to do with Friedreich's cardiomyopathy. It doesn't even perform the same. So, excuse me. So for them, the biochemical parameters that they need to look at, they're different. And the problems that they need to look at are different than what they were trained on. And unfortunately, because it's a rare disease, we can't do studies that say, this is what you got to do. Instead, all we can do is go on past judgment and what we have seen on these patients and make recommendations from that.
So in that vein, oftentimes clinicians will compare to a single value, which may have a wide range, which
Yeah.
means it's kind of noisy. Is there a reasonable number that we should use for FA kids as for wall thickness or?
Yes, we have very good numbers for children and for adults for wall thickness. We have very good numbers for what the ejection fraction and the diastolic parameters should be.
But are those going to be available to the
Yes.
garden variety cardiologist?
Yeah,
Yes?
if they don't know it,
Okay.
then they should re-examine their board scores.
Okay, fair enough.
We have very good numbers for biochemistry, cardiac troponin I, lipid panels, hemoglobin A1C. And these are, the reason I emphasize these is that all of these values have been validated in clinical studies that cover tens of thousands of people. So we don't want to reinvent the wheel for Friedrichs, because we can never get enough subjects to validate these studies. So, yeah, it's not the disease that the numbers originally came from, but we do have pretty good data on other diseases that have thick hearts releasing cardiac troponin, lipids in the blood, and hemoglobin A1C, diabetes, that do track with outcome. And so we can use those to help monitor and manage these patients. Yes?
Do you have any experience with pacemaker batteries
Yeah.
basically going, the battery depleting quicker with a person with FA versus a normal person?
So, is this a pacemaker or is this a defibrillator? Both. So, you bring up a really controversial topic. Again, I've not seen, what I have seen with the FA heart is implantation of defibrillator units, which is different than a pacemaker, a defibrillator unit, on the basis of the heart thickness. And so I think the American Heart recommendations, for example, don't go on the thickness of the heart, they go on the arrhythmias, because that's the component that's important. In terms of pacing, for patients who have atrial arrhythmias, sometimes implanting a pacemaker will fix that, and that's one of the reasons that we do that. So in terms of implanting pacemakers, yes, those may be very well indicated, and that's a fairly clear indication. If the pacemaker is being used a lot to drive the heart rhythm, then yes, the battery will deplete. Where it becomes very controversial is where we're talking about defibrillator units, and those are very different.
Is what?
Defibrillators,
Where it becomes controversial.
because in the guidelines for implanting defibrillators is not based on how thick the heart is. It is based on whether or not arrhythmias have been generated. Or, and this has become more common, if they have a gene defect that is known to track with bad outcome for hypertrophic cardiomyopathy, and some of the hypertrophic cardiomyopathies do have that, those are a different category. But the Friedrichs, we haven't seen fatal arrhythmias. I know of only one that was resuscitated. We haven't seen the kind of ventricular arrhythmias that would, if you followed guidelines, prompt implantation of defib unit. That being said, I never say it was the wrong thing to do because I'm not managing or treating that patient. But the thickness of the heart has not been the issue for arrhythmias and ventricular arrhythmias in this disease.
We have time for one more question, and then
Oh, I'm sorry.
people are gonna.
Did I answer your question? The batteries go down directly related to how much it's used to pace the heart or defibrillate the heart. So if the batteries are going down too quick, then the heart might be needing to be paced a lot more than what we suspect. But in terms of a defib unit, those are different. If those batteries are going down because of lots of discharges, then the heart needs to be further investigated.
Okay.
So that really is a complex issue. I'm not kidding on that one. There is one publication of a series from Germany where it was either 5 or 25 patients in whom they implanted defibrillators, and this is a very different thing than just a pacemaker. They did it strictly on the basis of the thickness of the heart. There was no clinical indication other than that. The patients never had any kind of arrhythmias. And I remember reading that, I was thinking, geez, I'm not sure they'd get by with that in this country today, because the defib units, they'll be $50,000 to $60,000, and they go off all the time, and they're very disruptive when you get shocked in the middle of your chest. Whereas the pacemakers, they're much, much less expensive, and they last much longer. So putting in a defib unit in these hearts, that's a hard choice to make, I have to say. That being said, there may have been arrhythmias, there may have been something
There
in
were
your heart that was different.
arrhythmias for you.
Okay, but the pacemaker is different. The pacemaker component, that may have been indicated, and it probably was. It may keep you out of atrial arrhythmias, and that's very, very important. So that's a very hard topic to talk about in just a few minutes.
Correct.
I apologize if I didn't answer your question.
Yeah, that's
Okay. Do we have to
There's
go?
time for one more
Yeah, we're at 3 o'clock. You can stay for round 2. But I know, yeah, so 3 o'clock was sort of the time for the next round of sessions to start.
I do have a quick question for you. But you said on that website there, is there one for supplements?
In the clinical care guidelines,